All right, I want to first thank the speakers for taking time out of their busy schedules to meet with us and cover these topics and open it up to questions. Vinod?
By the third party testing doing the validation. Can you explain that? And also, what do you mean by the FDA registered laboratories? I don't recall anything like FDA registered laboratories. What do you mean by that?
Certainly. And Dr. Bassani can jump in on some of the registration components and the other standards that the laboratories follow. In terms of the utilization of these third-party analytical labs, which are FDA registered, again, he'll expand on that. These are labs that exist to validate the acceptable strength, quality, purity. If it's a sterile product, that it is sterile, that you have content uniformity, that you don't have endotoxin limits exceeded in your formulations. These labs, particularly in the compounding world, exist to help the compounding pharmacies and pharmacists, as well as the clients that utilize them, assure that what they are intending to have in their compounded formulation is actually there. That it's in compliance with USP standards, that it's in compliance with whatever the state board's expectations are, some of which Dr. Shrewsbury talked about earlier. Gus, do you want to talk a little bit about the registration?
I don't know, maybe my FDA colleagues can comment, but there is a registration for laboratories, for analytical laboratories with the FDA.
You mean it is approved as an FDA laboratory?
Not approved, registered with the FDA. Like, so the place where the pharmacy sends the preparation to be tested, whether it be for sterility, strength, endotoxin, and the like, those laboratories can register with the FDA.
Okay. John, you want to go? I think you were next.
Yeah. So, it's fine. Clearly the panel consists of people who are thoughtful and careful about what they do, harking back to what Dr. Carr said earlier, which is that individual patients need individual therapies. And I think Linda McClenny talked very nicely about the fact that there are certain things that we can do that make a huge difference in patients' lives. And I guess, John, you talked briefly about the fact that there were a host of compounding pharmacies or compounding groups that committed fraud and did other things. And, we clearly understand that the spectrum of this is very, very large. All of you are involved in fairly comprehensive groups, and they are careful about what they do. On the other hand, there are compounding pharmacists who exist in small communities and do other things and work in different ways. And I think one of the problems that we're wrestling with in terms of thinking about all this is how to look at that spectrum. And so actually I would go to Dr. Shrewsbury to ask, how do you suggest that we think about maintaining the ability to create new compounds or new issues and new ways of treating for patients like the young patient that was just described, and yet protect the population and the public from problems that occur? And that's sort of where we're stuck.
I think that the new compounds will come from people who are innovative. I think that there's always people, as has been mentioned, there's a lot of different excipients, there's a lot of different ways of doing things, there's a lot of different concentrations, and it's an untapped resource of how many variables there can be. So I think those will surface. In terms of how to get that information out and how to, if you will, regulate that information, the states have to do that. I mean, they're in charge of compounding, even though the FDA does have discriminatory enforcement power. But honestly, people who choose to be compounders make a choice that was stated that you're going to do things differently. You're going to look at a different set of literature. You're going to have to become different than just filling prescriptions. And I think that's the point that we try to get across in schools, is that is a, if you want to call it a specialty in pharmacy, which is perfectly fine to call it that. But if you pick that specialty, you will be a specialist, and you will take on the characteristics of a specialist. You will learn your trade. You will learn it well. You'll have to go to classes that other people may not go to. You need to keep up with the literature. And yes, you yourself may be creative. I mean, you may be trying something that you think might work. I mean, there are things that I do only because I have some experience with, say, ingredient A, and I give it a shot. And so I think that's always going to be there. I don't think that's going to go away.
And just to follow up on a particular point, which is slightly different, which is that we talked about, there was a suggestion that maybe the keratinocytes can directly affect the nerve endings in the skin, and we're certainly learning a huge amount about the role of cells beyond the nervous system in that process. However, is there a differentiation in what you do between what you're trying to do, which is to treat locally, versus the systemic absorption of the drug? And in particular, focusing on a couple of things. One is ketamine, and the other one is clonidine, because those two drugs clearly have significant side effects. And what I would ask is there a standard to looking to see whether they're actually absorbed? You know, in the hospital, you could actually measure levels, I guess. In individual patients, you could actually measure levels. But our understanding is that that's rarely done. And so is there a way of understanding whether we're putting somebody at risk if they spread ketamine gel all over their body or clonidine gel all over their body?
Yeah.
And then that leads specifically to the question of, it sounds like all of you provide your patients with information about the safety and efficacy and the limitations and the dosing and all the rest of that. But it doesn't sound like from this morning that there are any requirements that information be conveyed. And I wondered what your thoughts were on that. So the issue is the absorption versus the local action, and the second is providing the safety and efficacy information to patients, and I'm happy to have whoever.
I'll add 2 cents, and maybe you can add a few cents. I think that's a very good question, and I think surface area comes into play. I mean, I think even the approved lidocaine products. I mean, you apply them all over the body, you're in trouble. And same, I think you could say the same for ketamine or clonidine. Certainly, clonidine has impact on the cardiovascular system. The one thing that I'm trying to educate my colleagues on a little bit in the industry is we interchange the terms transdermal and topical or permeation enhancing and transdermal. I think from a nomenclature perspective, a lot of what's going on in there is topical permeation enhancing vehicles, and we use sometimes, I think, the word transdermal, and that means something very different to people within the FDA, within USP, within industry, because that typically means that we're trying to achieve a systemic level. But in my experience, and my colleagues can chime in, so often we're achieving therapeutic effect peripherally. And we know now that there are opioid receptors peripherally. We know there are NMDA receptors peripherally, et cetera, alpha-2 receptors. You know, the transmission of neuropathic pain is quite complex. So I think by and large what people are trying to achieve is more peripheral action. To answer your question about systemic risk, you know, there's probably a need there. There's probably a gap there that we need to understand, you know, what is the risk, but it's hard to execute when you're dealing with bespoke extemporaneous approaches.
So let me push back a bit. The issue is that, yes, you're trying to achieve a dose locally, but as indicated by a recent article in JAMA, even suntan lotion can achieve certain levels in the blood, and if you measure things carefully enough, you get there. So my question to you is how do you decide what the level that you're willing to accept is, or what's safe or what's not, and is there a formal understanding of that in a way that would allow us to protect people from the the potential serious downsides of too much of a systemic level.
If we can get this question answered quickly and then move on to a couple other ones, because we're running up against the time limit for the cafeteria, so.
So the quick answer is patient monitoring. As discussed, this is customized medicine. When you're dealing with customization of any product, you typically have more communication, more contact with the people who are doing the customization of that product. And for medicine, that's particularly important. The NABP Model Pharmacy Act does talk about a requirement for patient education on a variety of points, and that might be written or verbal education of the patient. And every state board of pharmacy has a requirement for how we educate our patients, how we counsel our patients for whatever the medication that they are receiving, especially if it is a new prescription. So that does occur, and it occurs in various formats depending on the nature of the medication. A lot of times they're utilizing information from the FDA-approved products, because these are not novel chemicals. We're not creating new molecules that we're treating our patients with. These are products that are largely already components of FDA-approved products, and so we're looking at the adverse event profile from those systemic products to understand what might be possible for our patients. So, for example, with clonidine, if that's in a prescription, the patients are always monitored for watching for signs of hypotension, for example, just as one example. Colleagues may want to expand.
Carmen or Steve, I don't know who was first there.
Yeah, everybody outlines some really nice.
Microphone.
Everybody outlines some really nice procedures, but I wonder, just continuing back to the FDA group, are there any regulations that would require all compounded pharmacies to comply with really any of the procedures you outline? That would those, that would ensure consistency among products with any one of them?
Well, one thing I would answer is that if the state mandates that pharmacies comply with USP regulations, in both 795 and 797, you are required to have what's called a formulation record, which tells you what the recipe is that you are going to make in detail. It gives you the procedure, it gives you the equipment, any kind of testing that you're going to do, and it also mandates that you fill out and complete what's known as a compounding record every time you make that, and that becomes part of your quality control. So by having those documents there, and they are required to be there, you should at least start out having the same product each time it's made if they follow the formulation record.
But there's no regulation that requires them to be consistent. There's no written regulation, and all the states don't adopt USP.
Well,
right?
that's true. They don't all adopt it, but I'm not sure I agree with your statement that there's no written regulation. I mean, if you're ordered by the state to comply with USP, then USP standards are written, and they're there.
I believe if I'm a pharmacy and I make a preparation and I label it for gabapentin 6% topical, and it's not what it's labeled to be, I believe, correct me if I'm wrong, FDA, but I believe the agency could say that that's adulterated or misbranded, right?
Maybe.
Well, and also in health systems, the Joint Commission that accreditates health systems, they require USP standards, so we absolutely have to follow those standards. No matter, even if it's not recognized by the state, we have to follow it. So any hospital that's accredited by the Joint, they have to follow USP standards.
And I'll add in one other component about the comment of the adoption of USP standards. While not all states may adopt USP standards directly by reference, a lot of that has to do with legislative requirements within those states. So most of those states will adopt not by reference, but they basically type up their own copy of USP standards, because those are the rules. For example, in the state of Colorado, I've been advised by some of the pharmacists and the inspectors in the state that they don't refer directly to USP because they have to make the regulations available to all of the registered entities, and they couldn't afford to buy a copy of the USP standards for every pharmacist in the state.
But there's no complete requirement, correct?
If you're looking for a national standard that says everybody has to do the exact same thing, I believe you are correct. That
Okay, I just have one
There's
more
no
question.
there's no requirement for release testing, if that's what you're getting
Well,
at, for
I had
each
a
compound.
question related to that. Is the API verification, is that USP is, in general, is compounding pharmacy, when the API comes in, do they verify that it's a USP, it meets all USP standards?
The pharmacies themselves?
Yeah.
Typically, they rely upon the repackagers, see a certificate of analysis, but I mean, they can do testing on their own too.
But they, again, they don't verify that themselves.
No,
That's-
usually entities like us would verify that, yeah.
You would, but
Yeah.
not everybody would.
Well, I mean, they're required to, so.
But, okay.
Let's go to Carmen, and then we'll wrap up, I think.
So I'm seeking to understand, and I was sort of struck by the fact that it seems like a lot of this is private pay. The patient pulls money out of their pocket. Would you agree with that? So that means we're really talking about a select part of the population that can actually, one, afford this. So I'd love to hear, one, how much do, for instance, you talked about a patient, the 90-year-old patient, how much that costs that particular patient. And then the other question that I would ask is, you said it was out of the ordinary that you went up to 20%, was 20% ketoprofen. How you made the decision that you could go up on that? And I mean, did you extrapolate that from the literature? How did you make some of those decisions?
So for that particular patient, for him, the clinical need was to get him off the Tylenol as quickly as possible because of the doses that he had been taking, unbeknownst to his prescriber. He had been taking it for, I think, at the time we were involved, it was up to 8 or 9 months at that point. So we came up at that point. Typical starting dose for us at ketoprofen is 10%. It is not unusual for us to have patients that are on 20 and as high as 25%. So in that discussion with the prescriber, we said, we usually start at 10. If we're wanting to try to make sure we can cease the use of the Tylenol, I would recommend we start with 20. But again, this is going to require even closer monitoring for the first couple days to week to make sure that we're not seeing any adverse side effects or any issues with any drug interactions with what he's currently taking. And we both agreed to that. My staff performed every other day follow-up with him. And his staff was doing a weekly follow-up, so it was more than what we normally do above and beyond. But it in those cases where we stray from the start low, go slow, we up that increase of the patient input, the patient reconnaissance, if you will, to look to see what's
Can you
going on.
define follow-up? Are you getting routine creatinines and liver enzymes, or are you just making them a call and saying, are you feeling okay?
For the pharmacist side of it, we're doing phone call follow-ups. So, but for the prescriber side of it, there was that weekly follow-up. He was coming into the office for blood tests. What they were off the top of my head, I'm pretty sure we had a creatinine clearance on that. I know we had a CBC going on with it. I don't have all the data right at my fingertips, but he was doing weekly blood tests, and creatinine clearance was stuck in there because of that dose of the ketoprofen. So.
Well, I have about 30 questions, but we're completely out of time. There's no time for questions. So I think we're 5 minutes over. It's 1:20, so we're going to need to end this session. If you folks are here this afternoon, this has been wonderful. You bring such an important piece to this committee's deliberations. If you're here, I hope you'll be willing to at least answer some questions one-on-one individually as we kind of come back together this afternoon, okay? Thank you.